Welcome, and thank you everybody for being here. My name is Sarah Sims, and I am the manager of continuing education for the Brown School here at Washington University in St. Louis. Thank you everyone for joining us for today's Open Classroom program. If you're not familiar with Open Classroom, it is the Brown School's virtual and free professional development series. Beyond Open Classroom, we are the largest provider of continuing education units in Missouri and Illinois. So if you are looking for CEUs, or if you just want to take your learning a bit deeper, I invite you to check out our professional development website. It is at brownschool.woostel.edu under the Resources and Initiatives tab, and I'll put a link to that in the chat. We offer workshops year-round on almost a weekly basis, so we would love to have you all join us for more learning. Before we get started, just a very quick housekeeping item. As you probably already noticed, this is a Zoom webinar, which means that we can't see or hear you, but we do have the chat open to you all. So please feel free to leave any comments and especially any questions that you have in the chat. You can leave them at any point in time, but we'll save those questions for the end. We'll do a Q&A portion. You're also welcome to say hello and where you're joining us from. We're also going to stream live on YouTube, and I'll put a link to that in the chat as well. And a recording of today's presentation will be shared then on our YouTube channel. Links in the chat to come. But now I want to introduce today's speaker and presentation. So our speaker today is Dr. Megan Keys, who is a licensed clinical psychologist with expertise in the assessment and evidence-based treatment of PTSD. She has over 20 years of experience providing clinical services to adult trauma survivors. Since 2008, she has worked with the National Center for PTSD's Prolonged Exposure Therapy Training Program, providing expert consultation to VA clinicians learning this particular treatment. As an adjunct professor with the Brown School, Dr. Keys teaches graduate level coursework in cognitive processing therapy, as well as continuing education workshops for us in the professional development program. She is the founder of Trauma Empowered Consulting, which provides education and consultation services on trauma and mental health related topics. And today she is going to speak with us about navigating common implementation challenges in prolonged exposure, or PE, and cognitive processing therapy, or CPT. So I will now be quiet and turn it over to Dr. Keys.
Well, thank you so much, Sarah. Good afternoon, everyone, and welcome to Open Classroom. Thank you so much for joining us. We really appreciate your interest in this topic and hope that the content shared today will be helpful to you in some capacity. So, although I won't be able to view the chat box during this webinar, please feel free to engage with each other while I'm presenting, whether it's posing questions, reactions, or sharing resources. I really want us to optimize our time together in terms of everyone being able to connect and learn from each other. All right. There we go. All right, so just a few disclaimers before we begin. Although I am employed by the VA, today's presentation is not affiliated with this institution. All opinions expressed are my own. And the focus of today is to really enhance clinician self-efficacy when providing these treatments. However, this is just a gentle reminder to please always remember to work within your scope of professional practice. All right, so all right, 1 second, the slides are a little out of hand. Here we go. So this is an outline of our content for today. So working with professionals and students learning these treatments is one of my favorite things to do. So I'm really looking forward to sharing this information with you. Our goal for today is to really focus on addressing kind of core implementation challenges when providing PE and CPT. And since June is PTSD Awareness Month, I'll also be sharing some additional public resources at the end of the webinar. I anticipated that most people attending today may be somewhat knowledgeable about one or both of these treatments, but for anyone who is not familiar with prolonged exposure therapy or cognitive processing therapy, these next few slides are just going to serve as a brief overview. All right, so PE and CPT are considered first-line evidence-based treatments for PTSD. Each has a strong evidence base, but have also shown similar treatment outcomes when compared to each other. These are trauma-focused psychotherapies that view PTSD as a disorder of non-recovery. Both treatment models posit that avoidance, as well as maladaptive thoughts or beliefs, really play a key role in maintaining PTSD symptoms and preventing recovery. Although distinct protocols, research indicates that they share three core elements that contribute to treatment success, the three items listed at the bottom of the slide. However, how these elements are addressed really differs within each protocol. Right. So prolonged exposure therapy is based on emotional processing theory. Our conceptual model posits that PTSD results from maladaptive emotional structures that develop post-trauma, and these must be modified in order to promote recovery. These structures or networks are composed of three elements listed here on that first bullet point. For individuals with PTSD, there are often many inaccurate or faulty associations regarding the meaning of trauma-related stimuli and responses. And this is what results in the person often having an overgeneralized fear or emotional response to different trauma reminders. So let's say, for example, someone develops PTSD from a motor vehicle accident in which they were struck by a white pickup truck on the highway in the heavy rain. Following that accident, that individual may now associate highways, the sound of rain, pickup trucks, white vehicles, maybe even driving with danger, and experience a pretty significant fear or anxiety response when they encounter these trauma reminders, even though these stimuli didn't elicit any type of stress prior to having PTSD. Those faulty associations can only be changed when new disconfirming information is made available and incorporated into this network. So this is where our therapeutic exposure comes in. Therapeutic exposure to elements of that structure, such as trauma-related reminders, activate that emotional network and allow new learning to occur. So listed here at the bottom of the slide are our three primary treatment components in PE, including those therapeutic exposure procedures that we'll review in more detail shortly. All right, so this is just a snapshot of the protocol for anybody who's unfamiliar with it. And I just want to give you a sense of what those components look like over the course of treatment. So our first treatment component, psychoeducation, primarily takes place during session 1 and the first half of session 2. Our second component, in vivo exposure, or exposure to real-life reminders of the trauma, is introduced in session 2. We'll compose a hierarchy that's composed of various trauma-related items our client currently avoids, and they'll attempt to systematically approach these items over the remainder of treatment. Okay. Our third component, imaginal exposure, or revisiting the trauma memory, is introduced in session 3. So our client will participate in imaginal exposure and processing every session. A recording of their recounting of the memory will be sent home with them, and they'll have a chance to listen to this recording during the week in between sessions. So our two therapeutic exposure procedures, in vivo and imaginal exposure, will be consistently utilized from session 3 until the very end of treatment. Now, cognitive processing therapy is based on the cognitive theory of PTSD. So this conceptual model posits that PTSD results from disrupted schemas or core beliefs that develop post-trauma, and these maladaptive cognitions must be modified in order to promote recovery. So the traumatic event introduces new information that is discrepant to the person's existing belief system. Essentially, the trauma is so difficult to kind of comprehend and make sense of, it essentially overwhelms the belief system. And what happens is the individual subsequently has very extreme negative beliefs about self, others, and the world. cognitive restructuring of these maladaptive thoughts, which are referred to as stuck points, really help our client in the end have a more realistic interpretation of the trauma, as well as more balanced beliefs. So again, listed here are the 3 phases of treatment in which our client will learn a series of cognitive skills. And again, just for anyone not familiar, here's a basic snapshot of our protocol. So our first phase of treatment, psychoeducation, is the primary focus of sessions 1 through 3. Our second phase, processing the trauma, is what we really focus on in sessions 4 and 5 and a bit into session 6. We'll introduce different cognitive skills, and then we'll use Socratic dialogue to really examine our clients' stuck points and why the trauma occurred. Our goal is really to help them begin to identify these unhelpful beliefs and question them. Our third phase of treatment begins in session 6 when the client starts to learn skills to self-challenge their stuck points, as well as create alternative, more balanced beliefs. We'll also begin to address stuck points related to those key belief systems that were impacted by the trauma, which are the various themes listed on the right hand of the slide. So we'll explore these types of stuck points in the second half of the protocol. All of the cognitive skills have been introduced by session 7. The remainder of the treatment really is providing support and guidance to our client as they continue to practice and master these cognitive skills. So now, hopefully that everybody has at least kind of a rough idea of what these treatments look like, we will start talking about some of the challenges embodied in them. So I always think that a really important place to start is with the understanding that even though these are first-line evidence-based treatments, research kind of consistently tells us that they are underutilized in clinical practice. So listed here are just the most common barriers that clinicians tend to report in terms of implementing PE and CPT. But the reason that I like to highlight this, even for clinicians who may already be utilizing these protocols, is that some of these concerns don't only serve as barriers to initiating these treatments, but some of these concerns can still impact clinicians in the midst of treatment and really impact their decision-making and ability to be able to complete the treatment. So I think it's just important for folks to kind of roughly be aware of these. Treatment research has addressed several of these, and I'll be attempting to address some others over the course of the webinar. So research tells us that PT, PE, and CPT are effective in reducing PTSD symptoms, although a small percentage of individuals, usually roughly about 11%, experience symptom exacerbation. This is typically temporary. PE and CPT have been successfully implemented with individuals with a range of comorbid psychiatric diagnoses, and research tells us in the overall findings that these comorbid mental health symptoms tend to decrease post-treatment as well. And finally, both protocols have been found to be beneficial in treating PTSD in a range of trauma types, including in individuals with a history of multiple traumas or complex trauma. So before we jump into really specific implementation challenges, I just wanted to speak generally about some guidelines that can be really helpful with providing these treatments. So many of the protocol-related concerns listed on the previous slide really center on the rigidity of manualized treatments. Some clinicians are really genuinely surprised to learn that we have the ability to tailor these therapies to our clients' individual needs. So when addressing challenges, our role as the therapist is to really walk the line between fidelity and flexibility. We want to ensure that any modifications we make remain consistent with our underlying theory, as well as the evidence-based foundations of the therapy. It's important to highlight that PE and CPT are a collaborative process in which our client plays a role not only in the selection of their treatment, but the progression of their treatment as well. Emphasizing this cooperative nature helps strengthen therapeutic alliance, and engaging in shared decision making often enhances our client's sense of empowerment. We really want to be able to deliver a solid treatment rationale, essentially how and why this particular therapy is going to help the person by reducing their symptoms. We often return to our rationale multiple times over the course of treatment when addressing different challenges. Therefore, really mastering the skill of a good rationale delivery provides a very strong foundation for your subsequent trauma-focused work. And finally, just a simple thing to keep in mind throughout, especially when we're assisting our client overcome obstacles. These are labor-intensive treatments, and we really want to provide our clients just an abundance of support and encouragement to reinforce their efforts and their progress throughout. All right, so in terms of common challenges that both protocols share, these are the 3 key issues that I'd like to address for today. All right, the first challenge is increasing treatment engagement, as clients are sometimes reluctant to engage in these therapies. The starting point is often simply explaining why treatment is worth considering, namely that there is absolutely no need to live with the unwanted consequences of PTSD when effective treatments are available. Many client concerns about trauma-focused therapy are very similar to clinician concerns, namely worries about the emotional impact of the work. Investing the time to provide a solid overview of treatment and its effectiveness is often helpful, and I'll expand on that more in the next slide. Although avoidance is often a key barrier to treatment engagement, symptoms such as guilt and shame may also negatively impact engagement. Providing psychoeducation about how PTSD contributes to the intensity of these feelings can often be beneficial in enhancing motivation. And finally, and I think this is sort of the most important ones to keep in mind, another challenge is the misconception that clients need to be in an ideal situation in order to participate in trauma-focused therapy, namely that there's no co-occurring stressors or issues that could impact treatment. We don't want to jump too quickly to ruling out these therapies due to difficult circumstances. These first-line treatments are our most effective means of treating PTSD and remain our best option at this time. They teach our client a set of skills that's not only used to reduce PTSD symptoms, but it can be used going forward to address struggles in real life. All right, so with regards to treatment engagement, the National Center for PTSD provides educational materials for the public as well as professionals. Listed at the bottom of the slide are 2 resources that may be helpful in enhancing treatment engagement: an article or handout that provides detailed information about the therapy, as well as a brief video that explains PE. The content on the slide is just a very condensed version of the handout, just to give you a sense of the material, but it's user-friendly, it's a question and answer format, and it essentially addresses the key questions that people often have about therapy. And similarly listed here are the educational resources for CPT, as well as a condensed version of a handout. Now, these resources are helpful for clients, but also for loved ones and family members who may like to learn more about treatment. The brief videos, they run about 10 minutes, are really great resources to view in session with your client during treatment planning, if you are offering or suggesting either of these treatments, and really use that as an opportunity to immediately kind of address any questions or reactions they may have. Now, both treatment models posit that avoidance is a key factor in maintaining PTSD. So effectively addressing this issue is just essential for promoting recovery. Therapists are sometimes uncomfortable highlighting avoidance for fear of damaging the relationships in some way, that the client may feel criticized or they may drop out of treatment due to thinking they're not doing well enough. Validating our client's urge to avoid is a really helpful first step. Avoidance serves a purpose. It works in the short term and reduces anxiety. However, in the long term, anxiety worsens, avoidance increases, and PTSD is maintained. Consistently labeling avoidance as a PTSD symptom is really helpful in externalizing this issue, kind of making it something that is not intrinsic to the person themselves. This sets the stage for addressing avoidance as a joint effort between therapist and client. So I will often comment, okay, we both know that avoidance is one of the key things that keeps your PTSD going. So as a team, we'll each be on the lookout for avoidance. We're each going to call it out whenever we find it, and then we'll work together to figure out the best ways to start reducing it. Avoidance plays a huge factor in these treatments, and helping your client know that you're there with them to support them can often be a really great way, again, to kind of build that therapeutic alliance and making this aspect of treatment a team effort. Avoidance is sometimes due to a key concern or fear, such as the person being afraid they'll be overwhelmed by their emotions when they're faced with trauma reminders. This is where a lot of times returning to our treatment rationale or a specific component of our rationale and really addressing how treatment is going to address this issue can be helpful. All right, and then our third common challenge is homework compliance. So as most folks probably know, homework assignments and high homework compliance are related to better treatment outcomes. With PE and CPT, the majority of the therapeutic work takes place outside of session. So really emphasizing the role homework compliance plays in recovery is important. Problem solving, both logistical and clinical issues, is really helpful throughout this protocol. These are labor-intensive treatments, and life doesn't stop because we're doing trauma-focused therapy. Life goes on and gets in the way sometimes. So just be prepared kind of going into this that we really want to be encouraging and reinforce our clients' efforts made to attempt assignments, even if they aren't always successfully completed. We can use reminders or touching base by phone between sessions to help shore up homework compliance. And then finally, National Center has developed mobile apps for these treatments. So in addition to all your treatment materials being embodied in that app, it also allows your client to set reminders for homework assignments, therapy appointments, and completing their weekly self-report measures. All right, All right, so now I'd like to go ahead and shift into some of our clinical challenges very specific to PE. So my goal here is to really focus on a central challenge that therapists often experience when implementing each one of these procedures. All right. So I want to begin and spend the most time on imaginal exposure, as this is often the kind of therapeutic elephant in the room. Clients, as well as therapists learning this procedure, typically experience some level of anticipatory anxiety or uncertainty about this component. So just again, for anyone not familiar, this slide provides a general overview of how and why the client revisits their trauma memory in this treatment. The objectives of revisiting the trauma memory really are to help our client organize the memory and gain new perspectives, and to really help them understand the difference between remembering the trauma, an event that happened in the past, versus re-experiencing the trauma, feeling as if the event is happening again in the present. The key challenge that therapists often encounter with this procedure really centers on the question, how active should I be during imaginal exposure? So as therapists, our role is really to find a balance of leading and following our client through imaginal exposure. We want them to approach remembering and revisiting the trauma at their own pace, but we want to actively intercede when they encounter obstacles. So this was probably one of the most important things to remember about conducting imaginal exposure. Imaginal exposure is a process that takes place between our client and their trauma memory. As the therapist, we're on the periphery of this process. Their revisiting and recounting the memory aloud in session is not them telling us a story or conversing with us about their trauma. Our role is to really monitor and support this distinct process that's taking place between this person and their trauma memory. And then we want to kind of intervene as warranted. So our level of activity and imaginal exposure is truly dependent on our client's needs. The primary purpose of prompting for details during imaginal exposure is to promote emotional engagement. Our prompts should be intentionally timed, brief, and delivered in present tense. Prompting too frequently and using lengthy prompts runs the risk of disrupting engagement with that memory as opposed to enhancing it. It can be really helpful to begin with prompting for details of the event, sensory or contextual stimuli that was present at the time of the trauma. We can then use this as scaffolding to really prompt for the person's responses to this stimuli at the time of the trauma. And that includes their internal experiences. So some really common prompts to use could be things such as, what are you feeling when you hear the footsteps behind you? What are you thinking when you first smell the smoke? What's happening in your body when you see the gun? And this is just an example of how to really build that trauma narrative with details, which gives just more content for our client to be able to connect with and experience emotions related to that content. And then finally, just when identifying themes during imaginal exposure to discuss in processing, these themes often center on those strong negative beliefs about self, others, and the world around them. So a really helpful question to consider when listening to your client's trauma narrative is, what's preventing this person from coming to terms with their trauma? And then finally, I just wanted to highlight two narrative styles that sometimes require us to be a bit more active in imaginal exposure. Almost all trauma narratives involve some brief silences that typically dissipate over time, just through sheer repetition or prompting. However, when lengthy silences remain consistent, we really want to explore what's making it difficult for the person to verbalize those details. Avoidance of distressing content is fairly familiar, as is reluctance to share details that may involve feelings of guilt or shame. Validating these concerns, reviewing our rationale, and skillful use of prompting is often helpful, namely just encouraging them to be able to kind of keep narrating during these difficult intervals. Clients sometimes report having difficulty finding the, quote, right words to describe their memory. We really want to clarify that there are no correct words and encourage them to use whatever language they can, even if it isn't complete sentences or fully formed thoughts. A good general rule for imaginal exposure is, if it's in your memory, say it out loud with whatever words you have. And then finally, editorializing is a narrative style that is the direct opposite end of the spectrum. This is when our client tends to incorporate details into the trauma narrative that weren't actually present at the time of the trauma. So this can reflect avoidance, but it also can sometimes be our client's attempt to help us better understand the trauma narrative or provide background information. It sometimes can include reflective commentary of kind of how they've come to understand the trauma in hindsight, or feedback they received from others about the trauma after the fact. We address editorializing by returning to our rationale and reviewing the purpose of imaginal exposure, really encouraging them to remain focused on what happened at the time of the trauma, and then just consistently redirecting them as needed during the procedure itself. We notice them kind of trailing away and getting into editorializing. We can just simply say, let's come back to the trauma. What's happening now? All right, and so this is, again, an overview of the processing of imaginal exposure. So processing is a really critical part of exposure work. It is not simply just kind of checking in after the procedure to see how the person is doing. Processing of imaginal exposure is the opportunity our client has in session to really reflect on the trauma and how they're thinking about the trauma, especially as they're presented with new information and details from imaginal exposure. Our role is to really maintain the focus on what's going to provide them the most benefit while they're kind of exploring their thinking about the trauma. So this is just some general guidelines for processing. We explore a lot of different issues, but we always start with our client's experience of imaginal exposure, just their thoughts and feelings about revisiting the memory that day, as well as any changes in the memory, maybe new details or informations that were not previously recounted, maybe details or information that got dropped. We want to inquire what they learned from imaginal exposure, just new thoughts or insights, prior to raising our own observations, questions, or those themes to explore. When raising these issues, this is an ideal opportunity to address things like those lengthy silences or editorializing if that's something we need to explore. We really want to try to normalize our clients' reactions to the trauma by examining contextual details. Placing the trauma in context is an essential part of processing. When exploring some of those unhelpful beliefs, our goal is to really support the client in arriving at new understandings in their own time. So we tend to use reflective listening and clarifying questions to really assist them in examining their beliefs as new information is presented in imaginal exposure. And finally, just really encouraging them to elaborate on their thoughts and feelings, especially as new perspectives start to emerge, can be really helpful for them to start to differentiate how they're thinking about the trauma now as opposed to before. All right, and then our third kind of procedure or challenge centers around in vivo exposure. And so with in vivo exposure, the objectives really are to help our client break the habit of avoidance, but to also learn that these avoided situations are not dangerous. A common challenge therapists often encounter with this particular procedure is understanding how specific to be when they're creating in vivo hierarchy items or assigning and reviewing homework. So we typically generate about 15 to 20 items for the in vivo hierarchy that are representative of the activities the person avoids. However, we tailor the hierarchy. We want to tailor the hierarchy to try to be meaningful to our client. We want the items to reflect as much as possible kind of how our client would like their lives to look at the end of treatment. However, we need these items to be practical. It's really important to confirm that our client has access to the activity, can engage in the activity for an extended period of time, usually 45 to 60 minutes, and can also participate in this activity multiple times a week. One of probably the most common challenges for therapists is really understanding how to take a target activity and then manipulate different variables to generate multiple items that have varying levels of distress. So listed here, I took the target activity of just simply going to the store, but gave you a list of a lot of different variables we can apply to that activity to generate 3, 4, or 5 items that may have increasing levels of distress based on what our client is hoping to accomplish or what's really difficult for our client with this particular activity. Simply writing "go to the store" as an in vivo hierarchy item isn't sufficient. We want well-defined in vivo items in order to increase their chances of success with this particular procedure. Because all of our in vivo takes place outside a session, it is so important to be explicit when we're assigning or reviewing homework. When assigning, work with your client to clearly identify 2 or 3 items on the hierarchy that they're going to try to progress in the upcoming week. And then if you have the time, just review their weekly schedule. Help them get a sense of where and when they can fit in this homework to be able to get this practice in. It's also helpful to sometimes consider contingency plans in case issues such as transportation, weather, childcare may become barriers to their homework. And finally, if our client is just really struggling with a particular item, we can return to the hierarchy and review prior successes and kind of explore with them how they were able to accomplish those activities. And we always have the option of modifying that activity and breaking it down into smaller steps. The in vivo hierarchy is truly a work in progress, and we have the flexibility to adapt and add items throughout the program. All right, so now transitioning over to CPT. So for PE, we were kind of really in the trenches looking at a key challenge within each specific procedure. For CPT, we're going to step back and broaden the lens to really view kind of the overall protocol. My goal here is to focus on common challenges therapists experience across these three key elements of the treatment. And again, just for those unfamiliar with CPT, this slide highlights some additional information that it's just going to be helpful in understanding our implementation challenges. So as noted, CPT focuses on cognitive restructuring of trauma-related distortions called stuck points, and these stuck points fall into two categories. Assimilated stuck points are past-oriented, and they involve our client's beliefs about why the trauma occurred. Assimilation is often an attempt by the person to exert control and predictability over the trauma after the fact. Over-accommodated stuck points are current or future-oriented beliefs that involve our client's overgeneralized beliefs as a result of the trauma. And these typically fall within those 5 belief systems that we focus on during the second half of therapy. Over-accommodation is often an effort by the person to feel safer and more in control going forward after the trauma. Our goal of CPT is to achieve accommodation. Namely, we want to help them restructure all those stuck points and unhelpful beliefs so that they can have a more realistic interpretation of the trauma, as well as a more balanced belief system. Throughout the protocol, we utilize worksheets as clinical tools to teach our client these cognitive skills. And finally, I just wanted to list 2 additional CPT resources you may not be familiar with. The CPT for PTSD website is the official kind of website for CPT. It includes learning materials as well as several brief videos that explain the worksheets. And the book by Drs. Golovsky, Nixon, and Kaysen actually provides research-based adaptations to the protocol, and it is just a wonderful counterpart to the treatment manual. All right, so our first CPT challenge is mastering Socratic questioning or Socratic dialogue, which is grounded in a method of learning that really values a person coming to know something new for themselves versus being handed that insight or knowledge from another. Socratic dialogue is the cornerstone practice of CPT. We use this throughout treatment to really assist our client in learning how to challenge their stuck points and modify those unhelpful beliefs. It's through the process of Socratic dialogue that we really help our client gain a more realistic view about the trauma as well as its impact on them. So we will work with our client to identify a multitude of stuck points over the course of therapy, which they will keep track of in a little log. When we're actually exploring these stuck points, in terms of kind of our client's reasoning behind these unhelpful beliefs, when we're looking at why the trauma occurred, it's really helpful to initially focus on using clarifying questions to establish the context of the trauma. This often provides a much better understanding of the person's realistic abilities and choices at the time of the trauma, as opposed to their opinion of what they thought was possible in hindsight. When examining their reasoning behind a stuck point, it's really helpful to inquire about the person's intentions and expectations at the time of the trauma. This information is often useful when we start evaluating evidence that may or may not support the client's stuck point, particularly when these stuck points involve self-blame. Okay. And finally, just some of these stuck points are very deeply entrenched. It's really hard for the person to even consider an alternative perspective. And a lot of times at that point, it's worth just kind of exploring the purpose of the stuck point. A lot of times what we find is that kind of holding on to these unhelpful beliefs really is protecting our client from the implications of changing their thoughts or beliefs about the trauma. Right. Our second CPT challenge is fostering natural emotions. So our CPT treatment model addresses the role of emotions in recovery from PTSD. Natural emotions are those feelings directly associated with the trauma, and they dissipate when experienced. Secondary emotions, these are referred to as manufactured emotions within this treatment model, are associated with those stuck points, and they dissipate when these unhelpful beliefs are resolved. So this a lot of times is where we see the really intense negative feelings around fear, guilt, shame, etc. A challenge for therapists learning CPT is really understanding how to support our client and enhance their experience of natural emotions during therapy. The thing that's important to remember is that Socratic dialogue is the tool that we use to elicit natural emotions associated with a trauma memory. Exploring those assimilated stuck points and discussing why the trauma occurred engages the trauma memory and produces natural affect. Now, this is not a formal exposure procedure, but I often encourage clinicians to really approach this process with the same level of sensitivity and respect we would any trauma narrative. Socratic dialogue provides our client the opportunity to safely and gradually access details related to the trauma, particularly those that may be painful and distressing and have been avoided, and gives them an opportunity to experience those related emotions. So listed here are just some simple suggestions that you can utilize in session for really optimizing our client's experience of natural emotions as you're exploring those stuck points. All right, and then our third and final challenge in CPT is prioritizing assimilated stuck points during the first half of that protocol. So again, this really is about exploring our client's beliefs around why the trauma occurred. And one thing that's really helpful for clinicians to understand is that the order in which we challenge stuck points really has an influence on recovery. We focus on assimilated stuck points in that first part of the protocol to facilitate the client having a more accurate understanding of the context in which the trauma occurred. We want them to be able to view the trauma in at least somewhat more realistic terms before transitioning to those over-accommodated stuck points, the belief systems that have ended up very extreme, which really center around how the trauma impacted them. However, because those over-accommodated stuck points are present and future-oriented, they pop up during that first half of the protocol while we're exploring why the trauma happened. So we just want to be cautious of not jumping from one stuck point to another. As much as possible, we want to maintain the frame and keep the focus on assimilated stuck points, our client's beliefs about why the trauma occurred during sessions 1 through 6. We can acknowledge the over-accommodated stuck points. We can encourage our client to write them in their stuck point log and then address them in the second half of therapy. The thing that's really important to keep in mind about this is that usually our Socratic dialogue around these assimilated stuck points is really what helps our client understand eventually that the trauma really was unforeseeable and unpreventable. Clarifying questions and putting this trauma back into context often helps the client realize that many of those if-only options that they thought of in hindsight were simply not realistic options at the time of the trauma. All right, and then I just wanted to quickly walk you through some resources I thought might be useful. Listed here are just various educational and training resources for these treatments. The initial bullet point under each of these is the formal training and consultation programs through the official programs if you're interested in becoming a certified provider. PE Web and CPT Web are self-paced online courses developed by National Center for PTSD and Medical University of South Carolina, but they utilize a lot of training videos. So you really will have the opportunity to see therapists implementing pretty much every component of these treatment protocols. All right, so these are resources from National Center for PTSD. I always love to share these because they're awesome, and a lot of clinicians aren't really fully aware of everything that's available through National Center. So although National Center is part of the VA, the resources are not just for veterans who experience military trauma. Many of these public resources were developed for survivors for a range of traumas, and their homepage also has some resources for PTSD Awareness Month. For professionals, so National Center offers numerous educational webinars and online trainings. They also offer access to various PTSD and trauma assessment measures. The thing that I really want to highlight is their national consultation program. So this program, that very bottom link, it provides free consultation to non-VA providers working with veterans with PTSD. However, in light of the pandemic, this program expanded their services. So they continue to offer free consultation to non-VA providers working with anyone, veteran or civilian, that is struggling with mental health issues as a result of the pandemic. It's very user-friendly. When you're on the site and you'd like to submit a consultation request, you just submit an electronic request that briefly describes kind of the issue or problem you would like help with. Then the program will seek to match you with one of their experts who specializes in that area. And finally, just a few more PTSD resources I thought may be of interest. Here at Brown School, our professional development program provides an advanced learning certificate in the assessment and treatment of PTSD, and this will be offered in the fall of 2024. So this educational program will involve instruction in PE and CPT. I'm a co-developer of this program along with my colleagues Ryan Lindsay and Julie Basnick. We'd love for you to consider joining us if this might be of interest to you. ISTSS is a professional organization, but it does provide a range of clinical and public resources available to non-members. So you can review those on their website. And then finally, for anybody who's just kind of interested in PTSD in general, this is an open access article that was just published about a month ago through Current Neuropharmacology. It is a masterful review article regarding the current state of PTSD treatment. So it not only includes our evidence-based psychotherapeutic and pharmacological interventions, but does a great job summarizing a lot of the emerging treatments and kind of what we know at this point in time. All right, so in conclusion, these are just some take-home points. For those of you already utilizing these protocols, I hope this webinar at least enhanced your understanding of how to address some of these challenges in some ways. For those interested in learning about these treatments, I really hope this content provided some insight into how these manual therapies really can be individualized to meet our clients where they are and to support them throughout the therapeutic process of recovering from PTSD. All right, so that concludes our content. This is my contact information, and we can go ahead and open it up for questions and discussion.
Awesome. Thank you so much, Dr. Keys. I have a few questions already right in the queue, but also folks, you're welcome to continue dropping questions in the chat as you like. All right. Okay, so the first one is, could you talk about if PE and CPT can work with EMDR treatment? And if so, like, do you have any suggestions about how that should be coordinated, or if there are any challenges with that coordination of treatments?
Okay, so at this point in time, if the question is about, is there a protocol or treatment that combines elements of PE and CPT with elements of the EMD protocol, there are no treatments like that I'm aware of. I would say EMDR is another one of the kind of really PTSD treatments that has a lot of evidence behind it. It kind of comes out third as more and more research is coming out. So I think that it's still a very solid treatment to consider. There isn't anything that I know of that really looks at kind of combining different elements. I would say there is emerging research in both PE and CPT that I'm aware of, where they are looking at sometimes doing combined protocols. Like there already is a PE and DBT, dialectical behavior therapy protocol, but I'm not aware of anything that incorporates EMDR. I would say just from my own experience, I have sometimes had clients who have presented wanting PE or CPT who may have already previously done a trauma-focused therapy. They may have already done PE or CPT or MDR. And I think my general rule of thumb is even if they have previously completed a trauma-focused therapy, an evidence-based focused therapy, depending upon what their symptoms are at the time, I still absolutely consider doing a treatment again. But part of what I really want to explore with them is like, when you did the previous evidence-based treatment, let's really talk through how that treatment went for you. What occurred in the sessions? What were the components of the treatment? How did the homework go in between sessions? Because sometimes what we discover is that perhaps even though it was termed one of these treatments, it wasn't necessarily on protocol and not all of the components were really utilized. Other times it may have just been a tough time in the person's life and they really didn't get a chance to do much of that between session practice, which is so critical for treatment gains and the maintenance of the treatment gains.
Thank you. The next two questions are kind of more about maybe challenges for folks accessing therapy broadly and how you might apply that then to these two particular therapies. So the first, we know from the past 3 years of the pandemic, just accessibility of like in-person, the ability of, to come to therapies in person, and the rise of telehealth over the last 3 years has been enormous, right? And so someone was just asking about, are these therapies that can be done virtually?
Absolutely. Absolutely. So both of these therapies, so telehealth actually within the VA healthcare system, they started using telehealth probably about a good 10 years before the pandemic. So even before COVID-19 hit, there already was a body of literature looking at the effectiveness of PE and CPT used in telehealth, and that has just dramatically increased since the pandemic. So yes, these are both treatments that absolutely can be delivered via telehealth and the effectiveness of them is found to be similar to that in person. And we actually have, Sarah, this may dovetail with what we talked about earlier. Back in the summer of 2020, when the pandemic started, Julie Masnick and I did an open classroom about engaging clients in trauma-focused therapy during the pandemic. And a component of that was focused on doing telehealth, and it looked at PE, CPT, and EMDR. So that is out there somewhere in our recordings that folks can access, and it'll give you a lot of tips and guide you towards resources about doing telehealth with these treatments.
It is. And in a moment, I'm going to drop a link
Awesome.
in the chat to all of our past, like where you can find all past recordings, and they are in chronological order. So that one was in 2020. So you'll have,
it was, I believe it was July or August of 2020.
Okay. So yeah, you'll have to scroll down quite a ways, but that is okay. It's all there.
And for our EMDR folks, it includes that as well.
Okay, great. The next one that I have is acknowledging challenges to engaging in therapies broadly related to a client's parts of their identities. So maybe, folks who have a particular cultural background or particular religious beliefs or practices that might make it difficult for them to either engage in particular therapies or just with their therapist. Any comments that you have or ideas that you have around that, particularly as it pertains to PE and CPT?
Yeah, so I would say, well, it's an area where we need a lot more research kind of desperately, but the research is slowly starting to trickle in terms of really looking at these treatments with specific ethnic groups and looking at the role of spirituality and religion. I would say the biggest thing for this is, depending upon your client, trying to be respectful of and address the concerns that they have up front about aspects of these treatments or elements of this treatment that might be conflictual or difficult for them based on their beliefs or cultural standards, and if there is a way to navigate those. So this is again where some of our flexibility comes in and really comes down to tailoring things to the client. The other thing though that I would be aware of, and what research kind of shows so far, is that because so much of both of these treatments is really helping our client make meaning of that trauma, the event that happened to them, and how to move forward, this is where we will often see a lot of these really individual factors come in terms of cultural beliefs, religious beliefs, etc. It may come through in themes in the imaginal exposure. It may come through in themes in their cognitive worksheets. And again, just the idea of really being aware of that, being respectful of that, and knowing that for them, we really want to be able to incorporate this into kind of their view of the trauma as well. So sometimes this is just really finding the balance. Again, our kind of bottom line is, if somebody came to you and said, Joe, I would really like to do PE, but for whatever reason, I just couldn't do the imaginal exposure. Well, then it wouldn't really be PE. So we'd want to consider, okay, well, maybe we could just do in vivo, or maybe we can consider CPT or something else. So we just got to make sure we keep those evidence-based foundational procedures as part of the protocol. And if we can't keep them as part of the protocol, then we're usually better off trying to consider an alternative.
Thank you. Okay, the next one is asking about what you might suggest for clients who live in neighborhoods or rural settings where gunfire is common, not just for vets, but for any clients that may have experienced trauma with gun-related incidents in everyday America, unfortunately. So, and I don't know, I'm going to interpret this question a little bit, are these therapies with they're used with any kind of trauma, right? It doesn't have to be a combat veteran experiencing that gun violence trauma, but it could be someone who experiences that in their neighborhood or right. Okay.
It could, but actually whoever raised this question, this raises a really good point, because if both PE and CPT, when we talk about wanting to help them modify these trauma-related distortions, and especially some of those kind of extreme concerns or views about danger and safety, we've got to remember what our goal is we want to change those cognitions in which they're viewing objectively safe situations as dangerous. We don't want to decrease or change views of danger when legitimate danger is present. And so this is something that a lot of times, even with PE, where I've worked with folks where depending upon the neighborhood they live in, depending upon the work that they do, if they're a police officer, security, a first responder, there are certain areas and certain occupations where a certain level of vigilance is actually normal and healthy and necessary. And so in those type of cases, we need to be really specific and really careful with how we're going to approach either some of these trauma reminders or some of these beliefs. And it really then is helping the individual kind of differentiate what is a objectively safe situation that you're viewing as dangerous because of the PTSD versus what is legitimately a potentially dangerous situation that anyone should be on guard of and be careful about. So that's again where this becomes highly individualized based on the nature of the trauma and our individual's kind of specific lifestyle or setting, depending on where they live or what they do for a living.
Right. So being able to see the intersections between the individual's PTSD and a potentially traumatic environment that they're living in currently.
Absolutely.
Okay. Another one. Can you speak about challenging avoidance in CPT groups, like sober living environments?
So for challenging avoidance, I would say this is where there's kind of a bit of a difference between the two protocols. So in PE, we're really directly tackling avoidance head on with the exposure work. In CPT, what they is really viewed as avoidance are kind of therapeutic interfering behaviors that would get in the way of the person attending their sessions, being able to discuss and work on these trauma-related cognitions and maladaptive beliefs in session, and then completing their homework, like really being able to work on this outside. Because any of the things that we're doing, especially with around why the trauma occurred, again, we're engaging that trauma memory at some level, and that's also one of those areas where avoidance naturally flares. So even though in CP the activities that are really addressing avoidance is their ability to be able to do those worksheets, come to session, think about, feel about, talk about those beliefs around why the trauma happened and how it's impacting them. That's what we're really focused on. And that's where we want to really be careful that avoidance doesn't flare up and get in the way. But we don't have specific, really behavioral assignments that directly address avoidance the way we do in prolonged exposure.
So that's a good stopping point because we only have 1 minute left. And so just a few reminders. First, that this session is recorded, and I put a link to the chat where you can review today's session and all other recordings. I also put a link to the Advanced Learning Certificate in Assessment and Treatment of PTSD in Adults, which Dr. Keys is a co-leader on. It's not open for registration yet, as it's not going to begin until fall 2024, but there is a place on that website where you can learn more about it and then sign up to receive an email when registration is available. So you can, make sure you have the opportunity to sign up if you would like to. And my last announcement is that Open Classroom is taking the summer off, and we are developing a new registration system. So we will be sharing new programs in the fall, and we hope that you continue to watch our website for upcoming classrooms. But thank you everybody for being here. And Dr. Keys, do you have any final thoughts?
I just wanted to just say one really quick thing, because I realized I misspoke. Our open classroom for the pandemic and telehealth was focused on PE and CPT. I'm getting my webinars confused, but we do reference a National Center for PTSD webinar on the similar topic, but that's the one that included EMDR. So the link to that is in the references. I don't want to send anybody in the wrong direction.
Great. And the slides and the references, I shared them here in the chat, but those will also be posted tomorrow on our website for anybody who had trouble downloading them from the chat. So thank you, Dr. Keys, for all of your great work and for your willingness to share it with us so thoroughly today. And thank you, everybody, for being here today.
All right. Thank you so much, everyone. We appreciate it. Have a great day.